Now, without further delay, let's begin today's event, again sponsored by Wolters Kluwer and hosted by Health Data Management, titled Cutting Edge AI. Should you take a chance? I'd like to introduce your moderator for today, and that is Lenny Liebman. Lenny, you have the floor.
Hey, thanks so much, and I do want to also welcome everybody today. I'm so glad that you joined us. I know that this is a topic that's on a lot of people's minds. We're trying to figure out how to use data in order to move some needles on our institutional objectives, and I think this is going to be a great opportunity for you to hear from a few voices, all each sitting in a different sort of complementary chair. That'll be real useful. Also want to encourage you, as Marvin just said, if you have questions, if somebody says something that you need them to elaborate on, if you want to challenge an assertion that you hear, please take advantage of the fact that this is interactive to go ahead and submit a question. I'm also going to be asking you a poll question in a minute, and I'd really like to have everybody respond to that so we have a statistically significant sampling from our large and diverse audience today. Good to see you all with us. I'm not going to talk about myself. If you're on these webinars regularly, you know who I am. I wrote my first line of code in 1973 and have been spending my time trying to figure out how organizations can leverage digital technology to optimum advantage for both themselves and the constituencies they serve for I don't want to say how many years, you do the math. But who I'm really excited to have with us is Ari Robiseck, who's Chief Medical Analytics Officer at Providence Health and was selected by HDM as a top 25 physician IT leader. I think Ari is going to give us some great perspective, real practical in the trenches of how we, again, use this technology to actually move the needle on those indicators that need to be moved so that our institutions can fulfill mission and also survive long enough to continue fulfilling those missions into the future. So I'm looking forward to Ari's presentation. And then after Ari speaks, you're going to hear from our sponsor. Jean-Claude Saghbini is CTO at Wolters Kluwer Health and really has great perspective. I mean, he's been around. He was CTO at WaveMark, which was a Boston startup, and we've been talking about Boston the whole pre-call, that was acquired by Cardinal Health. He's got not one, but 2 graduate degrees from MIT in engineering and business engineering. So, as long as you don't hold his education against him, I think you're going to find that, again, he has great perspective in terms of the technology. You can see he's worked for RFID-enabled solutions, so he understands the idea of sort of IoT telemetry. Just a great guy we're going to hear from after Robbie's presentation. But before we hear from either of them, there's 2 pieces of business that I'd like to do. One of them is I think it's really important that Ari, Jean-Claude, and I all know where you all are coming from. So here is a poll on your screen, wondering about what your personal top concerns about AI are. I'm asking you to just pick like 1, 2, or 3 of the following. I believe the polling mechanism allows you to pick more than one. Don't pick them all because then it's not a top concern. But you see the choices you have there? Are you concerned about if you can really get results that's effective? Are you concerned about what it is you have to do to make sure your analytic outcomes in terms of the sort of accuracy and precision of the information is best? Are you concerned about the fact that you're going to create these tools and nobody's going to use them? So that's the third one, adoption. Are you concerned about sort of engaging with the right external partners in order to get the technology and services you need to get the stuff done over both in the near term and the long term? Are you concerned internally, sort of how this gets funded within an organization that has a lot of conflicting priorities in terms of where budget dollars go? Are you concerned about learning more about sort of the risk exposures? So all the positive outcomes are well and good, but obviously there are some risk exposures associated with this, so you want us to talk about that? Or is there something I haven't put on the list at all? If that is the case, I'm going to ask you to do 2 things. One of them is to check the other box, but the other one is if you could use the Q&A widget to say, Lenny, the thing that's not on the list that concerns me is, and then tell me what that thing is, that will do 2 things. First of all, it will educate me about what I'm leaving off the list, and the other thing is we can actually raise that as a question at the end of the presentation. And through the miracle of the net neutral internet, I can share with you in real time, if everybody's clicked their answers, if you please make sure you click that submit button so that your answer is tabulated, I can go ahead and share with Ari and Jean-Claude, and with all of you, the results. So this is really interesting, and I may come back to this later and see what Ari and Jean-Claude think about this distribution. Kind of evenly distributed. I do see there's a few others I'll expect to see from you in the QA, but it looks like you're really wondering sort of that first one is this actually effective, and what are my risks? So I think it's just useful for us to kind of see what's on your mind. I am a little bit surprised to see that the adoption issue is a little lower than I thought it'd be, but we'll talk about that. Maybe we'll actually we'll elevate that concern for you. Okay, so I'm first up. So here's what I want to talk about. I want to talk about sort of why we're doing all this stuff, why this is an issue, and give some sense of how it is we can mitigate some of the risks. So human beings are just fonts of data. We just have all kinds of indicators, biological indicators, and also associated sort of demographic indicators, all kinds of information that we're constantly throwing off that could be captured. And like all other kinds of data, whether it's consumer behavior, whether it's financial markets, that data can be utilized. So there's clearly an opportunity here of some sort. I also want to put a little stake in the ground because while for editorial reasons the webinar uses the term AI, I do not want to get into a big sort of sectarian religious argument about what's AI and what isn't AI. One of the good lines you're hearing around lately is AI is what you say in marketing, machines learning what you say when you're trying to hire data scientists, right? So there's a variety of algorithmic heuristic tools that we can use and apply to data so that we can turn that data into actionable insight, whether we're doing taxonomies, whether we're noting anomalies, whether we're finding correlations, whether we're being predictive, whether we're looking historically to find root causes. There's a whole map of set of things that we can do. So instead of getting wrapped up in this case about what's AI, what's not AI, let's just use that as a placeholder to talk about all types of sort of, unsupervised learning and reinforcement learning and classification and other things that we do. Now, these techniques can also be broadly applied across our organization. I think this is an important point. Very often in these discussions, everything focuses on sort of clinical stuff, diagnosis, maybe image interpretation. But the fact is that AI, machine learning are being applied across the board. So sometimes it may be reading an image. Sometimes it may be allocating patients to beds. Sometimes it may have to do with ways of protecting against incorrect dosage. So there's actually a whole universe of healthcare problems that we can apply these technologies to. And as far as whether it's effective, although we're very, very early in the adoption stage, we are seeing leading-edge practitioners achieve a variety of results. I just threw a couple of these up here. Obviously, if you're tracking this, you might even know about the Beth Israel Deaconess research that had to do with sort of combining AI and human practitioners to read images. There's an interesting company called Verta, which has done a great job of sort of keeping diabetic patients on program, retaining them for a long period of time so that they're able to either reduce or eliminate insulin. El Camino has this interesting thing it does where, we have this exposure to patient falls as they go to the bathroom. Well, we have limited nursing staff, so how do we best allocate the responses of our nursing staff to patients who hit the button so that maybe we rush to those where we have risk and maybe we don't have to rush to some who are just, looking for, some help, some assistance, which is legitimate, but doesn't have to be responded within 30 seconds. And they've reduced their falls 39%, which is awesome. All using these kinds of techniques of assimilating data and applying sort of machine learning AI to that data in order to pinpoint what we need to act on and what we don't need to act on. So this is just how Accenture sizes the market. It's really moving fast. I mean, there's a lot of action here. So this is obviously like an 11x growth in 7 years. So there's clearly opportunity and going to be adoption here. Also, what's real interesting is not only to think about this in terms of individual institutions, but more broadly in terms of what's going on with healthcare overall, right? So we have a limited clinician supply. As we are able to do more stuff with medical tools and technologies, we're going going to experience this gap between clinician supply and clinician demand. So there are some social utility reasons why we may want to enhance our current clinician-based operations and human nursing operations with something that is machine-augmented. That said, this is actually far more complicated than I think most people understand. Well, I'm sure everybody on here understands, but sort of in the general narrative about this, I don't think people quite understand all the complex systems we have, all the multiple layers we have. Even our healthcare networks are kind of fairly complex in terms of which talent resides where. As we're sort of consolidating, we've got clinics here, we've got specialists here, we've got radiology there, right? So all of which already have their own systems. For some of us, our facilities have a certain age, and so we've got sort of even Wi-Fi issues. And in fact, sort of this is what the narrative generally looks like, right? So this is what hype looks like. Oh, you have all these data sources. You're going to apply some magic to them. A doctor or a clinician is going to get some sort of magical insight, know exactly what to do, and you're going to have a happy, healthy patient. In reality, this is kind of more how the sausage is made, right? There's a lot of diverse data sources. They have to be put through a whole ingest and integration process. You have to apply compliance, security, data governance rules to those. Then, in fact, where I highlighted in red, there is some sort of analytic operation that goes on, but even then you have to do the right visualization, and even then the results you deliver often raise more questions than answers, right? So there's this iterative process. Those little blue arrows going back are like, okay, well, you told me this, but now that I know you could tell me this, what I really want to ask you is that. And so we have this highly iterative process, and all of that has time and money associated with it, which are obviously unlimited. Clinicians have a lot of things to do besides, beta analytics, and hospitals and other providers have a lot to do with their money besides fund sort of informatics efforts. So this is the real world is much more messy. Also, as with every new technology, there's a lot of different ways that organizations can acquire technology. I mean, one model is certainly in-house, where the data science smarts and the analytic tooling become sort of part of the institution's enterprise environment. However, in many cases, especially since data science is in short supply, some of you are saying, well, you know what, we're going to hire some data science consulting skills, so some of the brains will be outside, but we're going to host all the data and the infrastructure because, we have either, HIPAA or whatever reasons that we want to do that. And, of course, there's this idea that a lot of healthcare AI is sort of available out of the cloud as a service, where you're getting the brains and the infrastructure and the results and the visualization and the best practices externally. Now, I'm not saying you have to choose between these. As a matter of fact, most organizations may use these in different ways, but I just think it's important to understand that technology like this is not something that simply drops out of the sky, but it has to live somewhere. And the people who have the insight and the understanding also have to live somewhere, again, whether it's in your organization, outside of your organization, or some combination of the two. So then the question becomes kind of what are some best practices that we can apply to our organizations if we want to achieve what AI will help us to achieve? What are some of the guidelines so that we can get the most efficacious results for the least resources? Not because we're stingy with resources, but the fact is that they're actually finite. So I'm going to give you sort of, I think, my top 8 list of things to consider. So the first one is to engage in some honest self-assessment. What skills do you really have? What kind of funding do you have? What you personally, what is it that you can or can't do to either champion or participate in an AI effort? I think this is really important because, again, it's easy to read a case study about some other organization and say, oh, well, we'll do it like they did it, but their self-assessment is different from yours. Every institution is different, so the road to your destination begins with an honest self-assessment about where you're at now, and that's not only where you're at technologically, it's also where you are in terms of culture and institution. Who's going to lead it? Is there funding for it? What problems are you facing? The other one is to make sure that while, again, that long journey starts with a single step, you do have to take a long strategic view of this. The incorporation of AI into your overall healthcare delivery strategy has to not just be about a specific project, but even that first project should keep in mind, where are you really trying to go? Again, are you trying to build a lot of capabilities in-house? Are you trying to focus on some of your specialties that are distinctive for your organization? Do you see yourself sort of getting into expanding, the size of your network? So is part of this the ability to scale your operations? Make sure that your AI strategy aligns with your institutional strategy. And the other one, which may sound like now I'm looking very short term, but I think it's important, the two are related, which is you got to prioritize which needles you want to move. You're not going to move all the needles with all the projects. So again, if the issue is, bed and capacity utilization, that's different than, if your problem seems to be readmits for a certain class of procedure, which is different than how it is that you apply clinical specialties as a resource optimally so that you can serve most people most effectively. So you have to, and I think Ari's going to talk a little bit more about that, which is sort of focusing on what am I actually achieving and how do I make sure I'm achieving that, opposed to just this general idea that I want to do a technology deployment. The other one I will put in here, which was interesting, again, in the poll, adoption by users came up a little bit low. I would say put a lot of weight on that. It really doesn't matter if you have great data science. If you don't have a way to coach, and that's why I'm showing our friend Greg Popovich there, right? If you don't have a way of coaching your talent into utilizing it, so you can have great technical results and no institutional impact if you don't make uptake an integral part of your program. Fifth one is to contextualize forward. This kind of goes with long-term strategy, but I think when I was talking about long-term strategy, I mean, what are the institutional goals? Here I'm talking about to contextualize forward how you're going to use analytics. Just because right now you're completely focused on bodies in beds doesn't mean that in 5 years you're not going to do much more remote care, right? Also think about your model right now that might be very clinician-focused, may include new personas like health coaches and chatbots and other tools, right? And that, in fact, even engagement with your patient community is going to change. So you have to really think about not what is my delivery environment today, but what are the personas and processes that I have to aim at in the future. It's like, Wayne Gretzky said, you skate to where the puck is going to be. So it's important that we always do that. Number 6 is to build compliance in. So I'll tell you this, if you're going to engage with some new hotshot AI vendor that doesn't understand HIPAA, that can't deliver the BAAs you need, and you think you're going to do the science first and do the compliance later, you're going to have a real problem with sunk costs and compliance failures. So don't try to, kind of glue these things together. It has to be built in from the beginning. So your CDO, your compliance officer, has to know what you're doing from step one. That doesn't always happen because a lot of people view the compliance team as sort of the department of no, so they want to do their data science stuff and then bring it to them and say, okay, we're going to roll this out. What do you think? That's really not the way to work. And another one is not to abdicate stewardship. So even if you engage with somebody outside your organization, which I strongly suggest that you do in many cases, that doesn't mean that you're abdicating leadership or stewardship of your effort to them. It just means that you're leveraging them as a resource. As a matter of fact, it is by picking their brains, it is by using not only their technology, but their service and insight component about the industry that you can actually up your own stewardship game so that, again, you're not just a passive acquirer of technology, but you're leveraging technology in in order to achieve institutional goals. And then finally, my number 8, and this is probably should have been first, but sometimes you want to put the most important one last. Where's the data? This analytics work is all contingent upon lots of data, lots of sources of high quality that's properly governed over time so that your results improve as you go forward. So don't just look at the sort of the promises of what the heuristics do. Look underneath at the quality of the data because, it's the old garbage in, garbage out, but I don't like that so much because it's not garbage that's going in, but if it's less than prime material going in, and if there's insufficiency in volume, you're not going to get the results you want. So you really want somebody who's aggregating large volumes of data and can help you sort of leverage that. And those are sort of the 8 points I had. I do want to encourage you sort of, again, to, if you haven't thought about sort of engagement with clinicians, to think about that, to think less about artificial intelligence and more about that you're augmenting intelligence. Those imaging results that we looked at earlier, that was the practitioners actually, the human practitioners actually outperformed the AI tool. So that looks like a failure of AI. But here's the key. When they combined the practitioner with the augmented help and support of AI, again, the results, the number of errors were decreased by a whopping 85%. And, 85% of 2.5% doesn't always sound like a big number, but every one of those is a human life, and we know what our exposure is when we make mistakes. And then finally, I just had to put in the perfunctory Dilbert cartoon, but I think this is really a relevant one, right? The visionary leadership is done. How long will your part take? I mean, this stuff is really blocking and tackling. And that's especially why I was glad to invite Ari on, because he's had hands-on experience doing that blocking and tackling. So without further ado, Ari, I'd love to turn it over to you, and you can talk to us a little bit about what you've done at Providence St. Joseph.
Sure. Thanks, Lenny. So a little bit of background about me first. I'm an infectious disease doctor and a hospital epidemiologist, and over the years, especially doing research work with large clinical data sets, I found myself more and more drawn to sort of the general questions related to ways that healthcare organizations can use their underlying data sets to improve care. And I worked in Chicago for a good number of years, and while I was there, I built up an analytics team, and we had a good number of data scientists, and we worked on all sorts of interesting machine learning projects. We developed tools to guide physicians towards which patients needed certain diagnostic tests or which patients were at risk of bad things happening to them. We developed a tool using natural language processing to figure out which patients were missing charges on their records. We developed a tool to optimize antibiotic choices. We developed, probably my favorite one, a tool for our population health team, helping them figure out what the optimal time of day was to call patients, time of day and day of the week to reach out to patients based on what we knew about those patients. And so did a lot of that kind of stuff. And based on that, I feel that I can very strongly endorse the kind of principles that Lenny has outlined. But when I was recruited to take the role that I'm in right now, where I coordinate clinical analytics for a 50-hospital healthcare system on the West Coast, what I discovered was that the key needs here were not so much ones where artificial intelligence, machine learning, et cetera, those technologies were front and center, but instead where those technologies were brought in to serve greater organizational questions. And this had something to do with the fact that our organization is a Catholic healthcare system. We care for many people who are not able to pay for their own care, and it has to do with the changing economics of healthcare, which I know many of the people in the audience will be familiar with, where margins for hospital systems are getting narrower and narrower, and we need to figure out how to optimize the use of resources inside our hospitals. And so what I discovered when I arrived at Providence was that the biggest need was not developing some cool new method for helping doctors with decision making. Instead, it was actually figuring out how to measure the value of the care that we provide in the inpatient setting. And when I say value here, what I'm referring to is clinical outcomes over cost. So are there ways we've been urgently asking ourselves to reduce the cost of care while maintaining good outcomes or even improving our outcomes? And so there are many challenges associated with being in a 50 hospital system, but there are some real advantages as well. And one of them is that we can learn from each other. So what I'm going to talk about is the technology platform that we've developed to help with this work, which I call value-oriented architecture. And you'll see along the way where using more advanced analytical techniques proved useful in serving the sort of underlying need to measure value better. So indulge me in a hypothetical. Imagine that you're a chief medical officer in a healthcare system, and you're given the data that's on the screen in front of you. So each of these circles represents one high-volume surgeon who does total knee replacements. And what we're looking at is each physician's average cost per case for these total knee replacements. And when I say cost here, the frame of reference is the hospital. So this is how much they cost us. We're not talking about charges. We're talking about true costs. And we've normalize these costs across our different hospitals, and so that we're making a fair apples-to-apples comparison of the cost to us when a surgeon does an elective, unilateral, primary total knee replacement in our system. And so what's striking is that the range of cost per case among these high-volume surgeons goes from about $10,000 a case to about $6,600 a case. These are all surgeons doing exactly the same thing over the same time frame. That's a big spread when you think about the fact that in a system like ours, we might do 15,000 of these a year, and we get paid pretty much the same amount, certainly for when the payer is Medicare or Medicaid. We get paid the same amount for every case, regardless of the cost to us of the decisions that physician makes. So if you're a chief medical officer in this hypothetical, which isn't so hypothetical, these are real data, the question that I'd invite you to think about is, what do you do about it in a world where what Medicare pays us for these cases is considerably less than the system average cost per case, which is where that black horizontal line is. And so what many CMOs do is they have a conversation with 3 or 4 doctors who are at the top of this graph. Those are the costliest physicians, and they work with them to try to figure out how to reduce their cost per case. And so we've modeled out what would happen if we brought every physician whose cost per case was above the 75th percentile down to the 75th percentile. And what we found was that would reduce our total cost per case for this procedure by 1%. Not enough to make a margin at Medicare rates. And so what we found, which I'm about to show you, gives me a lot of cause for optimism for the assertion that, in fact, the opportunity to reduce cost per case does not exist only among those 3 or 4 highest cost physicians. In fact, every single circle on this graph has a ways to move downwards. And here's why I think that. What you're looking at here is something similar. Each circle represents one physician who does a high volume of elective, primary, unilateral total knee replacements. But what you're looking at on the y-axis is the ratio of that physician's cost per case to the system average cost per case. So everybody who's above that black line is above average cost. Everybody who's below is below average cost. And what we're looking at here specifically is the biggest driver of costs in knee replacements, and that's the cost of the implant. And so the question that I'd invite you to think about is, for those doctors who are below the line on implants, meaning their cost per case is low on implants, do you think that their cost per case is also low on OR time, which is the next biggest driver of cost per case? So the answer is it's all over the map. Some doctors who are low on implants are high on OR anesthesia and vice versa. Meaning some doctors, while they're optimized in implants, they're far from optimized in OR cost. Unless you think I'm just cherry picking with my best example. Here's what things look like on pharmacy. See how many of those physicians cross over that line. They're low on one thing, but they're high on another thing. True as well if we include room and board. True as well if we include supply costs, and so on. And in fact, this is true even if you drill down to the next level. So I say, okay, let's just look at pharmacy costs. So we have some physicians whose cost per case is high, some whose cost per case is low. It's kind of a bimodal distribution, interestingly. And so, okay, everybody whose cost per case is low on pharmacy doesn't have an opportunity to reduce their pharmacy costs, right? Well, in fact, if you then unpackage pharmacy costs into the different types of pharmaceuticals that we use, start to find something like this. Here's the distribution of costs around pain medications. Here's the distribution of costs around the next biggest driver of pharmaceutical costs in these cases, which is hematological agents, and so on. So, coming back to this graph, if you're a chief medical officer, what you want to be able to do is to figure out not just who are my 3 highest cost docs. What you want to be able to figure out how to do is to identify where everybody has an opportunity to reduce waste in their practice, because everybody does. Or framing that in a more positive way, everybody's got an opportunity to learn from somebody else. And so the question for us information people is, how do you create a data platform that allows providers to see and react to information about where they vary in terms of cost per case compared to their colleagues? So if any of you are physicians or have spent any time in the company of physicians, you're going to look at this unidimensional graph and say, but that graph is unidimensional. You're missing something critical, which is clinical outcomes. You know, if I'm a physician, my cost per case might be high, but my outcomes might be terrific, and maybe my outcomes warrant my high cost per case. And so to represent the data in a way that is going to be actionable to physicians, you need to include the second dimension in this graph. The first thing that I'm going to do, though, before I add that is just flip the axis so that high costs are at the bottom and low costs are at the top. So you want to be higher up on this y-axis. But what about an x-axis, which is some measure of clinical outcome? And so where you want to be on this graph is in that right upper quadrant, where you're providing great outcomes relative to your colleagues for low cost per case relative to your colleagues. So again, the higher up you are on that y-axis, the lower your cost. The further to the right you are on the x-axis, the better your clinical outcomes. So I call this a value plot. And so is a value plot something that's creatable in real life? And the answer is yes. And here are the steps that we've gone through in our organization to be able to create visualizations like the one on the top right of the screen. The first thing that you need to do is to figure out how to define your clinical cohorts. And what you discover very quickly when you speak to physicians is that oftentimes you can't rely exclusively on administrative data for identifying your clinical cohorts. We found, for example, that DRGs just aren't an adequate way of pulling together the sort of cardiac cases that allow cardiac surgeons to say, yes, when you compare me to that guy, you're making an apples-to-apples comparison. So I go through this 3-step process when I meet with clinicians about building these out for their specialty area. The first thing I ask them is, how do you define your cohort? And sometimes it's a matter of relatively straightforward things. We're pulling data out of a registry, or we're using some combination of DRGs, ICDs, et cetera. But sometimes, for example, when we sat down with the spine surgeons, they said, well, a critical stratifier in our cohorting for spinal fusion cases is how many spinal levels we operated on. And the only place that you can get that is in the operative note. We actually have to build a natural language processing tool so a good example of where we're using advanced analytical tools to serve what is conceptually a straightforward process. And so we actually had to build an NLP tool to read the spinal operative notes and figure out how many levels they operated on so that we can use that for cohorting and risk stratification. Another thing we ask them is, how do you risk stratify, again, for fair apples-to-apples comparisons between physicians or between hospitals. And sometimes what we'll need to do is actually build out predictive models using the clinical and administrative data available to us so that we can do fair risk stratification. The third thing we do is, I call it a give a darn test. It's the way that we get at what outcomes physicians really care about. And what I say to them is, imagine an outcome that might be on this scorecard, and imagine that I told you that on this outcome, you're doing way better than your colleagues. Would you feel good about yourself? And if I told you you're doing way worse than your colleagues, would you feel motivated to change your practice? The answer is yes to both of those. That's an outcome that we want to include in this. That passes the give a darn test. And so that's the third thing that I work on with physicians, are what are the outcomes that we want to pull into this. What we then do is we pull in our costing data, and I won't belabor this, but we normalize our costs so that our costs are comparable between one hospital and another, so that if a doctor, there are true differences, our accountants will tell you, between the cost of a day in a non-telemetry bed in our hospitals in Alaska versus our hospitals in California. But that's not a difference that is in any way affected by that physician's decision-making. And so to put physicians on a level playing field and only show them differences in costs that are driven by differences in their decisions, we normalize these costs. We then fit all of the costs into a costing taxonomy that we've built. So we have hundreds of thousands of individual cost items. Every med is a costed item. Every unit of blood, every MRI of the whatever is a costed item. We fit these into a taxonomy that allows for drill down by users of this tool into clinical categories that make sense. We then pull together the data that pass the give a darn test about the outcomes of interest. We pass all of this through a statistical engine that allows us to call out individual physicians or hospitals who are significantly different from their colleagues. As I mentioned, we need to build a natural language processing tool. So on the left, you've got the sort of note that we have to deal with, and we need to translate that into, this was spinal fusion and one level was fused. Another thing that we do is provide in our visualizations for an individual type of costed item what the potential is for that physician to reduce their cost per case. And the way we identify that potential is we use a clustering algorithm to take all of our physicians, create a histogram looking at their distribution of cost per case for that specific item. In this example on the screen, we're looking at cost per case for pain meds in knee replacement surgery. And we then use our clustering algorithm to break this histogram into distinct practice patterns. And then the one furthest to the left is the reference practice pattern. So long as it has at least 10% of physicians in it, that becomes the reference group. And so when we say to a physician, here's what your opportunity is to reduce cost per case in pain meds for this type of procedure, we can point to what their cost is per case and what the reference group cost per case is. So another example of sort of a more advanced analytical technique that serves what we're trying to achieve here. So here's an example of a real value plot. This relates to coronary artery bypass graft surgery over the last couple years over the last year at several of our hospitals. These are our hospitals with larger volumes of these cases. Remember, where you want to be on a value plot is in that right upper quadrant, so relatively low cost, relatively good outcomes. Here, what you're looking at on this x-axis is a composite score that we've needed to develop that uses a weighting technique that takes into account the sort of variance of each of the individual outcome metrics that go into it. And So this outcome score combines all those different outcome metrics onto a single axis, but users will have the ability to choose any one of those specific metrics to be represented on the x-axis if they want. So in this particular example, you can hover over that hospital at the top right, and what this little tooltip will tell you is that their cost per case is significantly lower than that of their colleagues, and their outcomes are statistically significantly better than that of their colleagues. I might hover over this little circle towards the bottom, and what the little tooltip will tell me is the statistical test that lives behind this identified this as a high-cost, significantly high-cost hospital, but their outcomes are not significantly worse. Users can access the same data at the level of the individual provider if they want. And just to give you a quick example of the way something like this can be used in real life, it's a little hard to tell perhaps if your screens are as blurry as mine, but what I've done here is switched the y-axis from total cost per case to just laboratory cost per case. I was sitting down with the CEO of one of our regions recently, and we were noodling around with the tool, looking at exactly the data that you're looking at, and what we found was that this physician's hospital was very high on laboratory costs, because now the y-axis is just showing lab cost per case. In fact, his hospital was the one sort of right at the bottom of the graph, SMCCH, and compared to one of his competitors also within our system, which is kind of high up on this graph that says PSVMC. Their laboratory cost per case was quite low. So you can actually click on one of these circles, for example. So I'm clicking on the one at the top, and on the right-hand side of your screen, you're seeing on the top a trend line which shows what's happened over time to their lab cost per case. They've had a big drop recently, and that's statistically significant. You can tell that because the circles towards the end of that trend line are green. So what's their competitor doing that's different than what they're doing? So users have the ability to drill down into this next screen where they choose these two specific hospitals, the PSVMC and the SMCCH, look at their laboratory cost per case, and then use that cost taxonomy that I described to drill down into what are the drivers of difference in cost per case. So on the left-hand side, you've kind of got one level of drill down, which shows that the lab cost difference is driven by general chemistry, and then you can click on general chemistry and see on the bottom right-hand side of the screen that one of the major drivers of that is differences in cost per case on blood gases. And remember, we normalized all these costs, even though they're different hospitals. And so the difference here is entirely being driven by differences in utilization. The users also have the ability, for example, to look at this data broken out into different sort of risk strata so that they can do real kind of fair apples-to-apples comparisons. And I'll just sort of jump to the end here where we now have the ability to model out what would happen if we use the sort of benchmarking technique that I described and all the physicians in the system migrated over the course of the next several years towards those sort of benchmark costs per case. Oops. I will stop there, but happy to take questions afterwards.
Wow, that was great. And sorry we had to rush you at the end, but it's about quarter of. We do want to take some questions, and I do want to hear from Jean-Claude, but I just want to point out a couple of things. I mean, first of all, the importance of this visualization, and even the difference between sort of presenting raw cost versus ratio is interesting, and just the way that you've now sort of wrapped up on this last slide to show what the results are. I mean, that's pretty dramatic. I'm kind of interested in the dollar and outcome story, but I'm not sure you can share that with quantitative precision right now in a public forum. But Jean-Claude, you are next up, and I know you have some real interesting things to talk about that may answer some of the questions we have already. So why don't you share with us?
Absolutely. Thanks, Lenny. So the big question is AI a pill to cure healthcare? And we believe that it is not the pill to cure healthcare, but it's certainly going to play a very important role in our future. So with that in mind, what I wanted to do is take you through 4 fundamentals that we see as being key to succeeding with AI in healthcare. The first one is, first fundamental is about having knowledge and domain expertise. The second one is about data and a data strategy. The third one is getting into the data science and how to apply AI to the data itself. And the last fundamental is about how to take the solutions themselves and integrate them in workflows and ensure adoption. And the next series of slides, I'm going to take you very quickly through each one of these areas and provide some insights around them. So first, we start with content. We see it many times, and it's that sometimes people start with the data or they start with technology. But just like in any solution, we need to start with the problem itself. On the other hand, because the domain is very new, you need to be informed with the art of the possible. And this is where some of these educational sessions, etc., starts giving you insights as to what is possible and how are others solving some of the problems. You need to get buy-in in the sense that the problem is worth solving, but also have line of sight on to the fact that when the solution is finally there, how do you integrate it into the workflow, and how do you make it accessible and usable and ensure adoption? So that's the first fundamental. The second one is around building a robust data strategy. It starts with a strategy on how to acquire data and how to manage it. The key is having lots of data, but also having clean data that is labeled that you can apply machine learning to. And Ari mentioned an interesting thing around NLP. It turns out that in healthcare, most of the data is actually unstructured. About 80% of the data is unstructured, and as such, any data strategy in AI has to have a component to figure out how to move some of that unstructured data to the structured world so that it can be used in solutions. And finally, the AI data strategy needs to be coupled with a robust security strategy, data security strategy. Much of the data will have PHI in it, and even if it doesn't have PHI, we're going to be dealing with massive amounts of data where security has to be top of mind, and it has to be designed from the beginning into the data strategy. The third fundamental is the data science part, right? And I would say that AI is still as much art as it is science. So yes, we need to look at what technologies to use and apply to the data that we have, but also there's the people question. So who are the good data scientists? It's a very recent domain, and getting differentiation between data scientists is a tough thing. Getting training is a tough thing. So the people question is always top of mind, and I saw some of the questions show up earlier around training data scientists, et cetera. So that certainly should be part of the thinking as somebody's building a AI strategy. Partnership might be the answer, so rather than sort of hiring, partnering. And I would say that if you want to partner, you want to partner with institutions who have vertical domain knowledge in the space you're in. So if you're in legal, you want to do it with people who understand legal world, et cetera. If you're in healthcare, you certainly want to have partners who understand the healthcare domain. And the last point is that it's a rapidly evolving domain. So what was impossible yesterday might be possible now, and what's not possible now might be possible tomorrow. So keeping up to speed on how the domain is evolving is key. And the last fundamental is on the delivery. So to think of, are the solutions evolutionary, and can I put them in existing workflows, and how do I ensure adoption? Or they're revolutionary, and if so, how do I create new workflows that adopt the solution? And I'll give you my point of view on the how does AI play with the clinician space? hear a lot of questions or sort of publications out there on AI replacing clinicians, etc. The idea is not replacing clinicians; it's more augmenting and supporting clinicians. I think Lenny mentioned that early on when on one of his slides. And success is about reducing clinician-computer time and increasing clinician-patient time, which has eroded over the past few years. And we're hoping to introduce solutions that bring that back. So with that, Lenny, I pass it back to you, I think, for the Q&A question.
Yes, we have a brief amount of time, so I'm going to ask you guys to keep the answers brief. And by the way, tons of questions, so I want to express my appreciation to the attendees, the level of this engagement. Ari, I feel like you stimulated a lot of discussion, and I may try to rope you into doing another one of these because you set off a storm of questions here. The first one I'm going to ask you is this notion of you kind of skimmed over it pretty quickly when you created your quadrant, your own little magic quadrant there. The cost axis is clear, but how did you sort of grade the clinical outcomes? Were you measuring readmissions, mortality, patient satisfaction? What the heck are what's the formula for that little axis there?
Yeah, so probably two questions built into that. One is what are the outcomes that we pick, and two is how do we weight them? So the way we do it is really we sit down with the clinicians in each relevant area. So we need to build this out separately for cardiovascular, then for orthopedics, then for general surgery, et cetera. But we'll meet with actual clinicians who do this all day, and we go through that kind of give a darn test that I was describing. But we try to kind of nudge them towards what I think of as a balanced scorecard, where we look at a combination of kind of traditional outcomes like readmissions, mortality where relevant, and complications, and where we also take into account patient experience and patient-reported outcomes. And in fact, part of what's been exciting about this project is that many more clinicians, now that we have this tool available, have signed on to a process of collecting patient-reported outcomes from their patients. So here I'm not talking about HCAP scores. I'm talking about asking their patient, about their knee function before and after their knee was operated on, for example. And then the second part of that is how do we decide how to weight them? And again, that's part of the sitting down with clinicians and figuring out what are the things that sort of motivate them most to change. And the reason I'm so interested in motivation to change is fundamentally that's what this is about, is everything needs to be able to kind of play in a way that it will motivate changes in physician behavior, because that's what we're trying to do here.
Yeah, I think it's really, really interesting to talk about how the metrics are not only sort of these abstractions of what do I think philosophically is the right weight, but once again you're showing a focus on outcomes by saying which factors should I weight because they will help me move the needle on that particular outcome. So I think that's really cool. Another question we have here is, while differences in cost per case are attributed to several factors, it doesn't appear to account for the variances in patient acuity. So do you want to comment on the role of cherry picking or anything else about the comment about sort of that divergence between cost per case and variances?
Sure. So anybody who's ever worked with, put data in front of physicians that's comparative in nature will have heard my patients are sicker. And so that's absolutely critical. And what I always say, how they say, just because you're paranoid doesn't mean they aren't out to get you. So I always say, just because they always say my patients are sicker doesn't mean that sometimes their patients aren't sicker.
Right.
And so we really, fairness is very important in getting physician buy-in. So a big part of what we do when we work with the clinicians up front when we build this, we figure out how they want us to risk adjust, so that we can make that comparison fair and so that we can deal with cherry picking. And I think one important a function for tools like predictive modeling, machine learning, et cetera, in this is actually doing that sort of risk adjustment or risk stratification. So, for example, in our cardiac surgery tool, we show raw outcomes for almost nothing. For almost all of our outcomes, we actually represent them as observed over expected ratios for how often these things happen. And so they almost all have predictive models embedded into them. So yes, great question, very critical.
Yep. I'm going to ask you one more as we get close to the top of the hour, if you want to keep this brief. This one says, Ari, great system, but what was the investment in time and money to craft it? So again, no, you may not be able to get into too much specificity, but maybe you can talk to me about what the institutional commitment was.
Yeah, sure. It's probably easiest to frame that in terms of the roles that need to be involved in making this happen. Number one, there needs to be kind of somebody who's able to provide project oversight, and I would say ideally a clinician who has some data experience and who can kind of talk to other clinicians and get them on board. You need somebody who can actually do the work of sort of sitting down with physicians and making sure that the data is legitimate. You need the sort of kind of data wranglers who can pull the necessary data for the outcomes of interest and validate them. You need obviously folks who design the underlying architecture for the sort of data structure that brings together the cost data and the outcomes data. There needs to be some place for getting cost data, although I would argue that everybody, good or bad, has some form of a cost accounting system. And you need somebody to build the visualizations. And, one of the things, you need somebody who's able to build the kind of statistical tools that live behind this. And the thing that was most unanticipated by us was the amount of training resources that we require as well now that we've built the tool and are rolling it out.
Yeah, and we saw some questions about training. Jean-Claude, I wanted to ask you one, if you can just answer it briefly, which is we have a couple of questions in here about, okay, this sounds great. How do I get started? I'm going to assume part of your answer is going to be click on the Wolters Kluwer website and talk to us. But any other tips about how people can get an effort off the ground?
Yeah, sure. So, I would actually maybe sort of go back to one of the slides that I had with the 4 fundamentals, right? So at the end of the day, you want to be informed with the knowledge in the domain. You want to figure out the data acquisition strategy, right? So how do you get the data? How do you sort of wrangle it? How do you massage it and make it usable? Make sure you have the team. Hire, contract, partner, etc., and keep an eye on delivery and certainly on getting quick wins. We see more value in short-term quick wins and getting things out there versus sort of multi-month, multi-year sort of investments where the light is always sort of far from you at the end of the tunnel. So that would be my advice.
Yeah, and I really think the two go together, right, because I think Ari gave us a great example of a sort of very specific win, but philosophically it aligned with a long-term kind of strategic view, which is we want to use this data to improve outcomes while at the same time putting some pressure on costs where it's reasonable to do so. Hey, we are at the top of the hour. Great presentations, guys, and we have tons of questions here. Don't worry, if we didn't get to your question live, we've got it here in the queue. So we will get you a one-on-one answer later. If for any reason you don't get an answer to your question, please reach out to me. You can find me on Twitter, on LinkedIn, however it takes it. But obviously I've asked you to ask the question. If you don't get an answer, I will be responsible for making sure that Ari or Jean-Claude or somebody else gets back to you. Want to let you know that you're going to get a link to this presentation on demand. Please share it with other people in your organization if you're trying to build some kind of consensus about a strategy going forward. Also, want to encourage you, if you found your time with us today worthwhile, keep your eyes peeled for future events. And again, thank you so much, Ari and Jean-Claude, for sharing what you have with us. I definitely encourage everybody here to watch what other institutions are doing and then don't do what they do. Learn from what they're doing, but find out, what your own institutional goals are and make sure that you're aligned with them, because that's the only way you're going to, I think, build the kind of institutional activity in this direction that's going to be so essential for us to survive and thrive in the future going forward. So on behalf of Jean-Claude and on behalf of Ari, again, this is Lenny Liebman. Thank you so much for your time, and have a great day.